Hi, this is Herb Kressel, and welcome to the February Radiology Podcast. This month we have two simulating conversations. First, I'll be speaking with Dr. Anand Narayan, formerly at Johns Hopkins University, who with colleagues reported on the impact of the Shared Savings Program for Accountable Care Organizations under the Affordable Care Act on screening mammography rates. I think you'll find this discussion of interest, particularly in view of the political dynamics underlying the Affordable Care Act these days. Next, my colleague, Dr. Albert DeRoos, will be speaking with Dr. Auer at the University of Nottingham, who with her colleagues reported on white matter changes in the brain in patients with cognitive impairment due to cerebrovascular disease. This is a very interesting and important subject, and I think you'll find the discussion quite interesting. As always, thank you for your interest, and we look forward to any comments you have on the podcast. Hi, this is Herb Kressel, and welcome to the February podcast. Today, I'm joined by Dr. Anand Narayan, who currently is a breast imaging fellow at Memorial Sloan Kettering in New York, and who, with colleagues, while he was in the Department of Radiology at Johns Hopkins, wrote a fascinating study looking at the impact of the Affordable Care Act's Shared Savings Program for Accountable Care Organizations in screening mammography. Welcome, Dr. Narayan. Thanks for joining us.
Pleasure to have me. Thank you so much for your time.
Dr. Narayan, can you tell us about the Shared Savings Program for Accountable Care Organizations under the Affordable Care Act?
Sure, I'd be happy to. So as part of the Affordable Care Act, there's funding in place for several demonstration projects that look at different models of physician payment. And one of previously the model for physician payment was fee for service. So somebody will pay me a certain amount of money to do a given service. And the thought is amongst various health policy circles that incentivizes people to do more. And with this new thought, with the Accountable Care Organization model, the idea is that you give a healthcare institution or organization sort of a fixed pot of money. And with that fixed pot of money, then it gives the providers and institutions that are doing this incentives to be more cost conscious. So along with that, the concern might be, if you just give an organization or institution a pot of money, they may say, hey, we can make more money by not doing anything at all for our patients. But the flip side of that is that the accountable care organizations also have various quality metrics built in to make sure that people are still doing a good job and still have good healthcare outcomes as well too. So the idea is by combining both of these things, the sort of incentives for sort of financial incentives, but then also to quality metrics as well too, that we can foster incentives that produce lower costs of care that also produce high quality healthcare.
So the idea then is if these accountable care organizations manage the money efficiently and have high quality care, that they can get back some of the savings as a bonus payments.
Correct. And the Medicare Shared Savings Program is the largest demonstration project so far in U.S. history.
Sure. So what actually are accountable care organizations? How are they formed, and who designates them as such?
Yeah, so there a wide variety of structures exist for accountable care organizations. Some of them may be run by hospitals, some of them may be run by physician groups, but nevertheless, it's sort of a group of providers, and within those providers, they're responsible for a certain population. And the denominator for that population can vary sort of considerably depending upon the region you're in and the population that they're responsible for. But once you sort of form one of these organizations, you may say then go to CMS and say, hey, for whatever population that's Medicare eligible or for whom it makes sense for Medicare, if you give us a fixed amount of money for these and we track all of the outcomes associated with this, if we demonstrate, then we can continue to keep high quality metrics, and if we save money as well too, then we'll participate in the savings of some of these as well too.
So in essence, they're provider organizations that are sharing risk for the care of a patient population.
Correct.
Okay, so now if these are supposed to share savings from cost reductions, where does screening mammography fit in? Why was that included?
Yeah, so there are several metrics that are in place. And as far as, so one of the things the accountable care organizations have to do is show that they show some level of quality performance as well. So they can't just be saving money. They also have to have quite high quality as well. And screening mammography is one of those metrics. In our world in radiology, it's one of the metrics that is tied specifically to population-based health, and specifically the percentage of population that are getting screening mammography. And I know there are lots of debates about how often people should get screened and when they should start and stop and things of that sort. But many of these organizations, from an accountable care organization standpoint, have some built-in metric there to say, because most people acknowledge that to a certain degree, whether it's every year or not every year, starting at 40 or not, but that mammography saves lives, and that people should ensure that their populations get a certain level of adequate mammography screening. So it's one of the metrics that are built in there, along with several others, to look at quality performance.
So how was if it's not cost saving, so what was the metric that was used to determine getting a bonus based on screening mammography performance?
Yeah, so it, as part of a group of many other metrics in terms of preventative health care, was one metric. It's called the ACO 20 metric, and it basically says, it looks at the population between 40 to 64, and it says how often do people get mammograms? So do they get mammography within every 2 years? And so that's one of the metrics that's built in with many of the others. So your performance on that metric is scored with many others as well too, and it's on a percentile basis. So if you with the other metrics as well to achieve a certain percentile, then you're eligible to get the money that you may have saved by participating in the accountable care organization.
I see. Now, going back to your study, what did you actually do? How did you address the question of what's been the impact on screening mammography?
Yeah, so we looked at accountable care organizations from 2012 to 2014, and what we did is we actually looked and saw, we looked at their numbers when they joined in 2012 and looked at their numbers when they last reported in 2014, and we wanted to see what kind of changes there were in mammography screening. So compared to baseline to the most recent time period, we found small but statistically significant improvements in this specific metric, the ACO 20 metric that looks at mammography screening in overall in the accountable care organization population. With some pretty large variation actually, but overall improvements in mammography screening.
So the overall improvement was an aggregate of 2.6% over, I think you had over 300 accountable care organizations?
Correct, yes.
But I was struck. I mean, some have said that this is relatively modest.
Yeah.
But as you know, 61% of the centers reported improvements.
Right.
So how do you reconcile these? It seems a little weird that you'd have such a large number reporting and then an aggregate have a very modest gain.
Yeah, so I think part of the thing is that within that small aggregate gain is a lot of variation. And I think that's the part that gets more exciting, because we were sort of strapped at an administrative level, sort of looking at organizations as units essentially. But within all those units are a wide variety of strategies for improving access to screening mammography. And I think that's the interesting part, where some of them showed huge improvements of 10, 20, 30% or so mammography screening. And I think there's a lot of information we could gain by seeing some of these organizations and seeing what are they doing essentially to improve screening mammography. And I think it's the incentive, and the fact that this metric is out there is encouraging in the sense that pushes people to improve. But I think the real information is to be gained by saying who's doing a really good job of getting screening mammography numbers to be up and to be improved, and then learning from those organizations and figuring out where we can go.
Very interesting. Do you have any examples of sort of successful strategies that you found particularly compelling?
Yeah, so there's a lot of anecdotal stuff, but sort of a lot of it revolves around communications with the people in a specific accountable care organization. So if you have your population of 30,000 people or something, some of the strategies I've talked about revolve around how you actually connect with those populations and make sure they're getting their screening mammography. So some strategies might say, for example, involve some level of communication saying, hey, if you have a pretty good data system in place and say, hey, we've noticed you haven't gotten your mammogram. It's been about a year and a half or so. It's about time. They may send that communication out in October just so that by the time December rolls around, they would have gotten a chance to do that. A lot of the strategies talked about, and a lot of this is at the anecdotal level. It's not formally studied quite yet, but a lot of these involve sort of like really connecting with your populations and your accountable care organizations to make sure they're getting their needed preventative services.
So very interesting. Now, what are some of the key take-home messages here? Do you actually think the Affordable Care Act has improved screening mammography rates? And how successful have these accountable care organizations been in terms of the other key metrics? Is what we've seen in mammography, is that consistent with the overall experience?
Yeah, I think it is consistent with the overall experience. I think we're still learning a lot about these and these different measures in place, essentially. So first of all, I think one thing is these are all relatively new, so I think we're learning a lot about these experiments in terms of payment reform. And as we kind of see more of these things and we learn from who's doing well and who's not doing well, I think there's a lot more information to be gained. But I think the preliminary evidence is positive that if accountable care organizations and the Affordable Care Act has had some positive impacts on mammography screening. So I think, we have more stuff in the future as to look forward to in terms of like these different experiments and learning from these as much as possible. But I think so far initial indications are positive.
Very good. Dr. Narayan, it's been a pleasure speaking with you, and thank you once again for this fine article.
My pleasure. Thank you so much for your time.
Hello, I'm Albert de Roos, Deputy Editor for Cardiovascular Imaging, and I'm joined today by Dr. Dorothy Auer from the Division of Clinical Neuroscience at the University of Nottingham. And we like to discuss a forthcoming article in Radiology entitled Lesion Topography and Microscopic White Matter Tract Damage Contribute to Cognitive Impairment in Symptomatic Carotid Artery Disease. Welcome, Dr. Auer.
Welcome, and thank you for having me.
So we were very much interested in the topic you have been describing in one of the next articles in Radiology. And as a starter, I like to invite you to give a flavor of the background and the motivation for this study so that the listeners and viewers can understand what the actually motivation and interest of your study is.
We all know that we are living in an aging society where dementia plays a key role, and a lot of focus is on Alzheimer's disease, with an increasing understanding that vascular dementia may play an equally important role. And as a neuroradiologist, I'm very interested to see to what degree advanced neuroimaging techniques can help us to better understand and better diagnose patients at risk of vascular dementia.
Okay, so in Alzheimer's, there is a discussion about vascular disease which may exacerbate the disease process. So that's an interesting position and an interesting topic to research. And what was your specific purpose to solve this problem and to address this issue?
That comes also a lot from my clinical practice, where we are commonly asked to comment about whether a patient with early signs of cognitive impairment is likely to have Alzheimer's disease or vascular disease. We were just commenting on the degree of low density changes on CT, which we all know is not really good enough to predict vascular dementia. So one of my big motivations was to use the advanced brain imaging tools that we have at hand as researchers to see whether it could help to improve the diagnosis of people at risk of vascular dementia.
And how you selected these patients and what were you actually studying?
Yeah. So the patients selected for that study were people with advanced vascular health problems, particularly people who presented with carotid artery disease, who we followed up for the prediction of eventual stroke. So we knew we have the cohort of patients with a high risk of cerebrovascular changes. We had the opportunity with advanced imaging to look at the network changes and the structural, microstructural abnormalities in their brains and correlate that with their vascular performance. We then set out to analyze specifically the differences between cognitively impaired subgroup and the cognitively intact subgroup.
So you apparently wanted to select patients with a vascular risk defined by carotid artery disease. are you thinking that the carotid artery disease will be the driver of those changes, or is just a general marker of vascular health?
I believe that it's more a marker of vascular health, and that's also partly informed by the findings we have. We had, however, the opportunity, because some people presented with transitory ischemic attacks or stroke, that we could look directly at the acute lesion load and work out which of the two was driving the cognitive status of these people. And the finding of the paper is that actually it is more the cumulative overall vascular abnormality in terms of the poor vascular health, rather than the particular ischemia that were at the heart of the presentation. So that's something we found in the paper that we are describing.
Before we get to the actual results, can you still describe your MRI protocol and which features of the brain you studied with the MR protocol in these patients?
Yeah, so this is an elderly population, so we were keen to have a short and brief brain imaging protocol that could be used in the clinic later on. So there are actually two key components of it. One is a classical FLAIR image to delineate the chronic lesion load. The other one is a diffusion tensor, pre-diffusion tensor sequence, which allows us to delineate the acute lesion load, but also the microstructural abnormalities by mirroring the mean diffusivity and fractional anisotropy.
Okay, and you used advanced techniques, especially diffusion imaging, diffusion tensor imaging, as a marker of early disease and microstructural disease. Is that correct? That
is correct. There's substantial evidence that we can use the microstructural abnormality with MD.
Okay, so you speculated that vascular abnormalities will go along with early white matter changes that could be detected by diffusion tensor imaging. And what were your actual findings? Because you also used the FLAIR technique to look at macroscopic infarcts and white matter disease. So what were the actual findings when you compared those patients?
Yeah. When we control for age in the cohort, which is important, we've seen that the lesion load from either acute or chronic had a very small effect on the cognitive status of the patients, whereas the cumulative effect in terms of mean diffusivity changes of the white matter tracts had the strongest effect, the strongest association with the cognitive performance of my patient population. That was the main finding. The second important finding was, again, what we hypothesized, that the location matters. Not only location inside of networks, but specific networks. And very interestingly, a lot of the specific white matter tracts from the thalamic radiation that we identified to be associated with cognitive performance are similar to previous findings for people looking not at patients with carotid large artery disease, but with diseases like CADASIL or small vessel disease. So there seems to be a common pattern emerging. It's not the lesion load that is relevant, but it's the location and the severity of the tissue damage that sometimes also goes unnoticed, which is the non-lesional part, something that the radiologists wouldn't pick up by just eyeballing the results of the brain study, but by quantifying specifically the amount of tissue damage.
Okay, that's an interesting finding. So not the macroscopic abnormalities are predictive, but more the microscopic white matter lesions. And you also had a distinction between patients with medial lobe atrophy versus a group without atrophy. And you said that you classified patients as probable vascular cognitive disorder. So how does this distinction work, and how difficult it actually is to make this distinction?
Yeah. This is part of also the motivation to do this study, because it's difficult for clinicians to be precisely sure whether this is more vascular. In particular, as you alluded to at the beginning, there's this comorbidity between vascular disease and Alzheimer's disease. So for the probable vascular disorder, we followed strictly the guidance by Warwick and others who have defined how the clinician currently tries to establish the diagnosis, which is basically there are two main elements for that definition. One is the definition that there is a criteria that there is presence of a vascular event, and secondly, that there is cognitive impairment, and thirdly, that they can be linked in a temporal context or potentially in a quantitative context. So this is the clinical definition. But we are aware that a lot of people can have Alzheimer's disease. So we were aware of that limitation of the study. And to address that, we looked at a plausible, reasonable marker of Alzheimer's disease, which is hippocampal atrophy. Mm-hmm. We estimated that according to well-established Shelton scale, and then found out whether the main findings I've just referred to were actually driven by people who have both probable vascular dementia and likely Alzheimer's disease. What we however found is that this is not the case. Also, those patients do not have hippocampal atrophy, and hence they are unlikely to be on the course towards Alzheimer's disease, have similar changes and similar effects from their microvascular damage.
Very good. So some people even speculate that dementia is decreasing nowadays because we treat all this vascular disease. So do you expect that your findings signify early disease, which could potentially be treated by vascular health treatment or any other intervention? What is your speculation in this regard?
This is a very interesting point. And in fact, our patients were chosen to not yet be demented. This is again this vascular cognitive disorder concept. They might be also by others called as vascular cognitively impaired. So they're exactly what you described, this early group of patients in the early phases where a successful intervention would be more likely to be expected than in those who already have the dementia. And we feel very much that these markers that we're trying to develop, like this skeleton MD, might be extremely useful to then observe the natural course and contrast that from a optimized health care management course by people getting them more exercise or potentially revisiting choline esterase inhibitors or any other pharmacological, non-pharmacological intervention. That's exactly what we're hoping to do, that we can help the field to develop the biomarkers as progression markers and then see whether the treatments would be effective.
Okay, very good. So some people may say there has been published already a lot on this topic, and there are so many confounders. It's so difficult to distinguish the effect and the result. So what are some weaknesses of your study, or maybe some issues that should be improved for future studies?
Yeah. So the obvious issue is that in order to be sure to what degree someone has Alzheimer's pathology before clinically manifest dementia, we would need to have amyloid PET, which is the best in vivo standard. We haven't had that in our population. So this is a clear limitation. We think the proxy marker of hippocampal atrophy is a reasonable proxy marker, but it's not the real thing. In terms of what this study adds opposed to what's out there already, I think it's important, exactly for the reasons we've been discussing, that this is a population of people with carotid disease as a marker of vascular ill health who are not yet demented. And the biomarkers that we've been proposing, out of the multitude of aspects, imaging markers one could choose, we propose a few select ones that can be now been put to the test by other groups. We are taking them forward ourselves, of course, for longitudinal studies, to addressing the remaining aspects of which of these markers that have been tested for their diagnostic value have actually predicted value. That is still to be done, but we are one step closer to doing that, and we are now looking at also at combining that with functional markers, looking at resting state analysis in conjunction with the structural data.
So you were mentioning the word prediction, and that's still not in your article, but are you aware of any results that were predictive in this regard and that other studies have shown that, or perhaps studies that are underway? Can you comment on that a little bit?
Yeah, so this use from statistical perspective is really only an association that we are describing, and that gives us enough confidence to then take them forward to actually assess whether this is predicting dementia. I'm not aware that there are data in the field of brain imaging studies like we've been doing, as opposed to hippocampal atrophy data, where there is already proven value to predict the development of dementia in the Alzheimer's pathology domain. So in the vascular dementia domain, this is early days.
Okay, so we have to look forward to future studies also by yourself. And I'd like to thank you for this discussion at this point. Thank you very much.
Thank you very much for having me.